So my name is Tae Won Kim. I am a full-time orthopedic oncologist at Cooper Medical School, Rowan University, Cooper University Healthcare, and the MD Anderson Cancer Center at Cooper in Camden, New Jersey. I am currently the division head of orthopedic oncology and the vice chair of the Department of Orthopedic Surgery, as well as the program director for the residency. I completed my residency at the University of Pennsylvania and then subsequently followed finishing my fellowship at Memorial Sloan Kettering Cancer Center in New York. I have been practicing orthopedic oncology since 2014, and I'm excited to be part of the future of orthopedic oncology into the 21st century. I chose orthopedic oncology for several reasons. The first is that it is a diverse field where we can perform surgery in pediatric patients as well as adult patients, and we do surgery in the appendicular and axial skeleton. The second is the longitudinal care that we can provide to patients over decades of time, and that we're not only their surgeons, but also their long-term physicians and doctors. The third is that orthopedic oncology is getting into the innovation sector, where technological advancements are starting to really have a positive impact on patient care. And I'm happy to be a part of pushing that envelope to try to improve the care of our patients who are suffering from these diseases. I'd like to go over some cases of how CurvaFix technology was utilized to perform percutaneous pelvic fixation in orthopedic oncology patients. Case 1 and case 2 will highlight pelvic deformity cases. So case 1, this is an AP pelvis of a patient who had metastatic breast cancer, who was subsequently treated with radiation and chemotherapy. She had a metastatic lesion in the periacetabular region as shown, and after treatment, unfortunately had a pathologic fracture that involved the anterior column of the pelvis. She was wheelchair bound with pain and was having a really hard time getting any sort of ability to mobilize out of the wheelchair. This is a three-dimensional reconstruction of the right hip. We show that a good amount of the acetabular dome and the femoral head acetabular congruency remained intact. However, she was initially indicated for percutaneous pelvic fixation and a total hip replacement at the same time. In the pre-op holding area, she unfortunately had developed a very significant fungal infection in her right groin, and therefore a total hip replacement at that time was off the table. However, I needed to place an anterior column screw for stabilization of the anterior column. And because of the deformity that existed, the plan was to utilize CurvaFix to address that pelvic deformity. So in light of the total hip replacement and the placement of the CurvaFix implant, I was able to place the CurvaFix implant to fix the anterior column. So these are x-rays of intraoperative fluoroscopy showing the significant anterior column deformity that existed, and utilizing the olive tip bent guide wire, I was able to get around the deformity and place a very long CurvaFix implant to address the pelvic deformity. This is the post-operative x-rays showing the implant was placed to gently get around the pelvic deformity. And she went home the next day. We used this pain and ambulatory function score. And what I found post-operatively was that she initially was wheelchair bound and had to be bed to chair transfers with assistance. And at 2 weeks post-op, she was walking with a walker with some moderate pain, which she had not been able to do for almost a year and a half. And she, at this juncture in time, is foregoing a total hip replacement because of how well she feels with just the anterior column screw fixation. What's also to note is that if in the future she does require a total hip replacement, the CurvaFix implant will allow her pelvis to remain stable and the acetabulum to remain stable. And I could also use it as a rebar to cement into it if I needed to for the future. Case number 2 is a 57-year-old patient with metastatic breast cancer to the pelvis. She was treated with chemotherapy and radiation, but subsequently started to have right pelvic pain. X-rays in November of 2023, as shown here, showed that she had a superior rami fracture with some possibility of an inferior rami fracture. Unfortunately, she was continued to remain non-weight bearing without further workup. And in March of 2024, came to me with a significant deformity of the right hemipelvis, as shown here, with a fracture of the iliac wing, the superior and inferior pubic rami, and she also was starting to present with systemic disease progression. Unfortunately, that patient really was not able to ambulate, and she was mainly wheelchair bound. And the goals of care here were, can we provide mechanical stability to her right hemipelvis without having her to undergo a very large pelvic operation? And that would also allow her to get back on systemic treatment quickly as she was having systemic disease progression. So with CurvaFix technology, I thought that I could provide this patient pelvic stability through percutaneous techniques and use CurvaFix to get around those pelvic deformities and allow her to get back on chemotherapy while also improving her quality of life. So these are some intraoperative fluoroscopic x-rays where I provided her fixation through a retrograde at this time, and that black blob at the top left is actually a 5.0 millimeter Schanz pin placed into the pelvis to allow me to have any sort of ability to manipulate the hemipelvis. We're able to then place that olive tip wire across that ramus, the anterior column deformity. And then subsequently, I stabilized her iliac wing by placing a second olive tip wire across the iliac wing defect. And I was able to use the Schanz pin to manipulate the pelvis just enough so that I could get around that deformity. These are her post-percutaneous fixation x-rays showing 2 of the CurvaFix implants traversing the pelvic deformity and pinning the pelvis in situ. At 6 weeks post-op, what I could tell you is that she went from a patient who was wheelchair bound, who needed assistance from a bed to chair transfer, and was now able to get out of the wheelchair and walk with a walker with moderate pain. Case number 3 is a patient who I used CurvaFix to not only navigate tight pelvic corridors, but to also revise a failed prior screw. So this is a patient, she was 61 years old, who was diagnosed with newly metastatic breast cancer 25 years after her primary tumor was treated. She had a lot of anterior pelvic pain, and on the x-ray, you could see that she had a lesion in the pubic symphysis area. We performed a retrograde percutaneous pelvic fixation with a rigid screw with a washer, followed by radiation. And she did well for about a year and a half. The screw had to be kept short because she had a very, very tight anterior column corridor, and it could not be navigated with the traditional straight screw. A year and a half later, she presented with increasing pain in her right posterior pelvis and right anterior pelvis. And a CT scan here shows that she has now a fracture of the anterior column at the tip of where the screw was. MRI here also shows that she had a concomitant sacral ala insufficiency fracture, causing her severe pain and difficulty ambulating. So at this time, the plan was to now fix the posterior ring by getting a transsacral transiliac screw, as well as take out the old retrograde screw and try to traverse the tight corridor via a antegrade approach. Intraoperatively, as we had seen in her prior surgery, the very narrow anterior corridor that you see here. And what we're able to do is take the screw out. We were then able to use the curved olive tip with the point, traverse that tight corridor, and at the same time, it allowed us to get across that sclerotic area where the prior fracture was, and allowing us to get a wire and a CurvaFix screw all the way down to the pubic symphysis. We also then were able to utilize the CurvaFix to place a transsacral transiliac rod, as shown here. And in this situation, I also had to use the new drill tip in order to get across the contralateral SI joint and iliac wings. And CurvaFix was the right choice for her, not only because of her sclerotic foci in the anterior column, but also the tight corridor in the anterior column, as well as my concern about the corridor size of the posterior ring. These are her final post-operative x-rays showing the CurvaFix implant traversing the anterior column across the tight corridor and sclerotic foci, as well as the CurvaFix implant going across the posterior ring and obtaining a transsacral transiliac purchase. The patient, prior to the operation, was walking with a walker with moderate pain. And after the operation, she stayed overnight and left the hospital walking with mild pain and a mild limp without the need for an assistive device. Case 4 is a case of a patient that require multi-corridor fixation. So this is a 71-year-old gentleman who had metastatic lung cancer to the supraacetabular region of the right pelvis, as shown here on this X-ray. It was lytic in nature, and I had initial concerns about the integrity of the supraacetabular dome, but in fact, it looked like it was still intact. He needed to go on chemotherapy for systemic control, but he was having severe pain with ambulation. So at this time, because of the lack of bone to provide a traditional anterior column screw, CurvaFix allowed me to think outside the box and perform what I call multi-corridor fixation. So in the operating room, the first thing we did is, as you can see here, we used a ablative techniques to essentially provide cryotherapy to the lesion to get some tumoral control in the local area. Then what I did is we actually utilized the iliac wing as my first site of purchase, and then guided the guide wire down the iliac wing corridor across the supraacetabular region and into the anterior column of the acetabulum. We were then able to get it all the way across to the pubic symphysis. And here is the post-operative film showing that with the use of CurvaFix, I was able to run a CurvaFix implant from the superior acetabulum across the supraacetabular defect and across the anterior column to the pubic symphysis. This patient initially was walking with a walker with severe pain. And after the procedure, 2 weeks later, when I saw him back in the office, he was able to walk with a cane with mild pain. In conclusion, percutaneous pelvic fixation is an important tool in the toolbox for orthopedic oncologists to treat patients with metastatic disease in the pelvis, and that the technology that CurvaFix offers is going to expand our indications and capabilities for treating these patients. As the science of percutaneous pelvic fixation in the treatment of orthopedic oncology patients continues to expand, we're going to require greater orthopedic oncologist buy-in in not only learning the technique, but also getting together to report the outcomes to show the importance of percutaneous pelvic fixation in these patients. For those orthopedic oncologists who have had experience in doing percutaneous pelvic fixation, or for those who are exploring the exploring learning how to do percutaneous pelvic fixation, CurvaFix can offer significant advantages, and I would encourage those faculty as well as residents and fellows to learn more about CurvaFix and how it can help patients with periacetabular and pelvic metastatic disease. Learning percutaneous pelvic fixation and becoming educated in percutaneous pelvic fixation requires buy-in from those who believe that this technique can not only help patients return to a higher quality of function, but allow us to potentially downsize to future operations that they may require. Attending workshops led by industry as well as our specialty societies are a great opportunity to start learning these techniques. And I would encourage orthopedic oncologists to attend those opportunities when available.